Hello, welcome to Lecture 5 of the Cardiovascular section of the Integrative Systems Physiology course. Today we will be talking about the changes in pressure and volume that occur over the course of the cardiac cycle, some of the additional events that occur throughout the cardiac cycle, and how we depict these collectively through an illustration called the Wiggers diagram. So in previous lectures leading up to today's lecture, we've largely discussed the general structure of the heart, so overall gross anatomy, the pacemakers and action potentials that initiate the cardiac cycle, how those potentials and subsequent depolarization events within cardiomyocytes result in normal and abnormal electrocardiographic changes, and then finally, how those electrical events elicit cardiomyocyte contraction on a cellular level. So today, again, we're going to be taking a step further to a larger scale by depicting some of the hemodynamic changes that occur over the course of the cardiac cycle using the Wiggers diagram. And so this is a series of traces that depict the electrical, the volumetric changes in the ventricles, and pressure changes throughout the cardiac cycle. And so, of course, throughout the cardiac cycle, we have two main phases, one being diastole, or the filling of the atria and ventricles, and the second being systole, or the ejection of blood out of the atria or ventricles. And so both the right heart and the left heart, of course, have the same phases throughout the cardiac cycle. So if we just walk through these here, whether we're looking at the right side of the heart or the left side of the heart, you can see that we start off with ventricular filling. We then move on to a period of isovolumetric contraction. So contraction is beginning to start, but the pressure within the ventricle has not exceeded the pressure outside of the ventricle, so either in the aorta or in the pulmonary artery, which would then open the valve and have anterograde blood flow start. So that's isovolumetric while pressure is building. Then we have ventricular ejection. So the pressure within the ventricle exceeds the pressure in the outflow tract, and the volume within the ventricles begins to decrease. Isovolumetric relaxation. So again, now the ventricle is starting to relax, but the filling pressure has not exceeded the amount of tension within the cardiomyocytes themselves. So we don't quite have filling yet. And then finally, we have ventricular filling at the end. And so again, things go in to the right heart from the systemic circulation, out of the right heart to the lungs, from the lungs to the left heart, and then out of the left heart to the body. So when we start to look at the volume changes that occur over the course of a cardiac cycle, you can see this is the initial part of the Wiggers diagram that we're going to start to commit to memory here. And so we've got both right ventricular volume depicted here and left ventricular volume. And you can see that we've got the late stage of diastole here, or ventricular filling. And you can see that right towards the end of diastole, when we're looking at the ventricle again, you've got this little additional blip here, which is right before the ventricle starts to contract. We get atrial systole. That's this little additional kick to sort of finish off ventricular filling. And then we move on to this period of isovolumetric contraction, and then subsequently the pressure increases in the ventricle sufficiently and the tension increases sufficiently within the ventricular wall to result an ejection or a reduction in ventricular volume that occurs in both the right and left ventricular ventricles, and then subsequently, as the ventricle starts to relax, then we go through isovolumetric relaxation and subsequently diastole and ventricular filling. And one thing that is important to note here, when you're looking at the relative scaling of some of these periods of events here, you can see on the right ventricular side that the periods of isovolumetric contraction are in fact shorter than they are on the left side of the heart. And of course, if you think about that, the reason for that is that the right ventricle is pumping blood out into a relatively low pressure circuit, being the pulmonary circulation. And so the amount of time that it takes to exceed that pressure and start to eject blood into the pulmonary circulation is relatively short. Whereas on the left side of the heart, it requires the generation of a substantially greater amount of pressure in order to overcome the amount of pressure that is in the aorta and subsequently result in ejection of blood out into the systemic circulation. And so we have longer periods of both isovolumetric contraction as well as isovolumetric relaxation, because it will subsequently take a longer period of time for that tension within the ventricular wall to dissipate. And so again, now when we're, and one other comment here, just when you're looking at the right ventricle versus the left ventricle, of course, over time, these two ventricular outputs, the stroke volume or amount of blood ejected per beat, has to be equal between the right and left side, because if they're not equal, then you're going to have the progressive damming of blood up in either the pulmonary circulation or the systemic circulation, ultimately, which results in a number of pathological problems. And so these, over time, in order to have homeostasis, must be equal in terms of the volumetric change on average per beat. So from this point forward for a bit, we're just going to focus predominantly on the left ventricle. And so you can see here, what we're going to do is we're going to place the electrocardiogram at the bottom here for our frame of reference. And so what you can see is back here, we've got this initial P wave, which is going to be initiating the cardiac cycle, the systolic phase of the cardiac cycle. So we've got atrial depolarization, followed by a period of where the electrical impulse is being transmitted through the atrioventricular node, subsequently to elicit a very rapid depolarization of the conduction system here, QRS complex, and then ventricular systole, and then followed by a T wave for relaxation. So when we start to look at this in the context of, some pressures, so when we start to look at pressures, what you can see here, we'll start off, for example, with atrial pressure. You can see when we look over here and we find atrial pressure, you'll see that atrial pressure, it really doesn't change appreciably over the course of the cardiac cycle. We've got a little color mismatch problem here, but you can see this is atrial pressure down here. Again, not substantively changing. You can see this little blip up here during atrial systole, but collectively, when we look at the atria, they're not incredibly muscular structures, and we like to keep the pressure within the left atrium relatively low, because of course that back pressure is also going to be transmitted back to the pulmonary circulation. So as left atrial pressure progressively increases, so does pulmonary circulatory pressure, and that ultimately results over the long term in pulmonary edema. So this remains to be a relatively low pressure over the course of the entire cardiac cycle in healthy conditions. Now, when we look at aortic pressure, you can see here that's depicted in red. And with aortic pressure, again, we've got this diastolic phase here where aortic pressure is relatively low. And then as the ventricle contracts, you can see that during this phase of isovolumetric contraction, there's no increase in aortic pressure, because at that point the aortic valve hasn't opened yet. The pressure within the ventricle has not been sufficient to exceed aortic valve pressure. And so technically, systemically, it would appear as though we're still during the late phases of diastole. But when ventricular pressure exceeds aortic pressure and is sufficient to open up the aortic valve, you can see then we end up having this increase in aortic pressure, resulting in a systolic anterograde, a rush of blood flow out to the circulation. The aortic valve then closes, and then we have a progressive decline in aortic pressure over the diastolic phase of the cardiac cycle. And importantly, we've got this phase here with the dicrotic notch. And so the dicrotic notch is really here because in large part the aortic valve closes. And then what we have is both the combination of a reflected wave as well as the elastic properties of the great vessels, such as the aorta, resulting in a secondary but small increase in pressure that ultimately allows for for a non-precipitous fall in aortic pressure over the course of the cardiac cycle. So when you think of this, what you really don't want to have is you don't want to have a bunch of stiff vessels where you pump blood in and then you get a bunch of blood moving forward and then it stops and then you have the subsequent injection of blood. You want to have blood pump into a relatively elastic system that some of the energy being stored in the larger vessels such as the aorta. So when there's a diastolic phase, then the blood that's stored as potential energy within those elastic vessels is used to continue to have anterograde blood flow during the diastolic phase of the cardiac cycle. So those are the two of the major pressures, the atrial pressure and the aortic pressure. Now, when we look at ventricular pressure, you can see that over the course of the cardiac cycle now, what we have is during diastole, late phases of diastole, we've got the atrial kick again here. We get a little blip up in ventricular pressure, but then as soon as we have the initiation of the QRS complex, you can see we get a rapid increase in ventricular pressure, and then which is initiating tension generation and resulting in isovolumic contraction. Then as soon as ventricular pressure exceeds aortic pressure, the aortic valve opens and we have this rapid phase of left ventricular ejection. Again, if you think back to the volumetric changes, there's a very precipitous fall in ventricular volumes during the early phases of left ventricular ejection. Subsequently, you can see there's a bit of an artifact here because of the elastic properties of the systemic circulation, and so you can see that it would appear as though aortic pressure is greater than ventricular pressure. Again, that's an artifact based off of measurement site, which is usually being done more distally, but the aortic valve is still open, so in the central circulation, there's still a substantial anterograde pressure gradient within from the ventricle to the root of the aorta. We then go on to a late phase of ventricular ejection or decreased ejection, so that the shallowing out of that lower portion of the volumetric change over the course of the cardiac cycle. Moving on then to isovolumic relaxation. So you can see now we are having a very rapid fall in ventricular pressure during this initial phase. And then ultimately, the mitral valve will open up, and you can see that ventricular pressure falls below atrial pressure. The mitral valve opens, and we enter a phase of rapid left ventricular filling. So again, this very exponential increase in ventricular volumes during the early phases of diastole. And then ultimately coming back to a period of decreased left ventricular filling, followed by then moving back to the beginning here with that atrial kick. And then we start back all over again with a subsequent cardiac cycle. So again, as we discussed, when we're looking at these changes in ventricular volumes in the context of the changes in ventricular pressures, you can see that there are not reductions in ventricular volumes until that ventricular pressure exceeds aortic pressure. And similarly, there are not increases in volume during this filling phase until ventricular pressure again drops below aortic pressure. And during the early phases of both systole and diastole are where we have the most rapid changes in ventricular volumes, and those tend to taper off as we get to the later phases of each respective component of the cardiac cycle. So now we stop and think for a second, well, what would you expect right ventricular pressures to look like relative to the left ventricle? So it's a little bit implicit at the beginning, but would you expect them to be higher, lower, or similar? Now, again, thinking back, the right ventricle is pumping blood into a relatively low pressure system that does not handle high pressures very well. The pulmonary circulation, very delicate structures designed to maximize diffusion and minimize the diffusion distance, maximize surface area. So again, when we're looking at the right side of the ventricle now, you can see that the pressures that are generated throughout the cardiac cycle are far lower during the systolic phase of the cardiac cycle. So here again, we have similar changes in the morphology of both curves. So you can see that ventricular pressure increases here, exceeds pulmonary arterial pressure. During the later phases of systole, we have this apparent point at which pulmonary arterial pressure is exceeding ventricular pressure. And then this artifact from measurement sites, and then again coming back down to a point where we have isovolumic relaxation, and then the subsequent diastolic phase. So all of the phases are very similar. It's just that the pressure changes are dramatically attenuated on the right side of the heart. Now, if we take those pressure changes and those volume changes, and we take the volume and we put them on the x-axis, and we take the pressure, put it on the y-axis, we can create pressure-volume loops and a pressure-volume relationship at the heart. And there's tremendous utility in using pressure-volume relationships to understand cardiac function in both health and disease. And again, the difference here, of course, there's no time being depicted here. The previous graphs are all shown with time on the x-axis. Here, it's just simply volume on the x-axis, pressure on the y-axis. And you can see as we're going through here, again, it's a very clear depiction of the phase where the mitral valve opens over here. We end up having an increase in left ventricular volume during diastole. Then pressure starts to increase inside the left ventricle. The mitral valve closes. We have a period of isovolumetric contraction as depicted here. And subsequently, pressure is sufficient to exceed aortic pressure. The aortic valve opens. We have this increase in pressure that results in an ejection of blood out from the left ventricle into the aorta. Then a period of isovolumetric relaxation. You can see there, the aortic valve closes. We have a vertical drop down in pressure here for isovolumetric relaxation, and then we go through the cardiac cycle again. So you should be able to go through and very readily identify points at which each appropriate valve is opening and closing, where we're having isovolumetric relaxation and isovolumetric contraction, and how these points on this pressure-volume relationship relate to the points that we try to highlight in the Wiggers diagram as well. So now we've gone through electrical events, we've gone through these mechanical events, and then of course we've got all these mechanical events, and it's interesting that there are actually the events that are occurring in the heart are sufficiently powerful enough to actually have sounds generated throughout the cardiac cycle in a very violent microenvironment. And so again, on the bottom, we'll put the electrocardiogram as a frame of reference, and of course everyone has heard probably their own heart sounds. Those are stemming from the vibration of cardiac tissues and oscillation of blood and during various portions of the cardiac cycle. And so when we're looking at what heart sounds are typically heard over the course of a cardiac cycle, there's the S1 sound over the cardiac cycle. So that is from vibrations stemming from atrioventricular valve closure. And so that is when the mitral valve and tricuspid valve are closing. And that is very early on during this isovolumetric contraction phase. During the S2 phase, the S2 sounds, those are vibrations stemming from semilunar valve closure, or the closure of the aortic valve and the pulmonic valve. And so those are depicted, of course, right at the onset of isovolumetric relaxation. So certainly within a normal heart, when you just think of the lub-dub sound or the boom sound, those are sounds S1 and S2. Those occur at the points in time at which the atrioventricular valves are closing, or the tricuspid or the semilunar valves are closing. Okay. For the S3 sound, again, now we're getting to more rare sounds, or sounds that might be indicative of pathology. And so here, the S3 sound is largely representative of oscillation of blood rushing into the ventricles during early diastole. So you can see here, again, during the very early phases of rapid cardiac filling, that is when there's potential for the S3 sound to be heard. And then the S4 sound is heard here. It's actually almost at the beginning of the cardiac cycle when you have the sound of blood filling a stiff ventricle. And that's largely associated with the oscillation of blood due to the atrial kick in late diastole. So only really with a stiff ventricle are you going to hear substantial and notable S4 sounds. So if we're thinking of how these go through, of course, it's S1 at the time, at the initiating point in time where you hear the atrioventricular valves close. S2 when you hear the semilunar valves, the aortic and pulmonic valves close. S3 with the rushing of blood in during early diastole, and S4 with an atrial kick into a stiffer ventricle. So again, we've got our phases here: left ventricular filling, isovolumic contraction, ventricular ejection, isovolumetric relaxation, and then back to filling. And when we're looking over the course of this cycle, much like many other muscular contraction cycles or periods where you have shortening of muscular tissues, it brings up a question of, well, how does left ventricular wall thickness change throughout the cardiac cycle? Because certainly if you think of other contracting muscles, if I just contract my bicep, for example, which barely fits into this screen of view, you can see that, of course, that the bicep muscle will shorten and thicken when you have contraction. And so and cardiac muscle is really no different with that regard. So when we're looking at changes in left ventricular thickness throughout the cardiac cycle, you can see here that, again, if we look at either the left ventricular free wall or the intraventricular septum, you can see that during these early systolic phases, that certainly diastolic, late diastole and early systole, that the ventricular free wall is relatively thin, and that over the course of systole, where we have reductions in ventricular volumes due to muscular contraction and the shortening of the cardiomyocytes, you can see that during systole, the left ventricular free wall gets significantly thicker during the systolic phase. That lasts all the way through the point of isovolumic relaxation until you start to have relaxation and rapid filling here, and then you can see the thinning of the left ventricular free wall as well. Similar patterns exist within the intraventricular septum. Again, I think you can look at this in a lot of complicated ways and get hung up on some of the minutiae. But what I really would like you to think of is just as a muscle is shortening, it is going to be thickening as well, and that has profound implications for how much work and how much tension is being generated in those tissues. And so just think of it this way: during filling, you're going to have progressive thinning of the ventricular tissues. During contraction, you will have thickening. That holds true for both the left side of the heart as well as the right side of the heart. And as you would probably expect, based on our prior discussion, since the right ventricle is pumping blood into a relatively low pressure system, the free wall of the right ventricle is going to be much thinner than it will be for the left side of the ventricle, which has to do a far greater amount of work pumping blood into the systemic circulation and a higher pressure aortic route. So when you're looking at the full Wiggers diagram, which will be posted on the physiology server, you should be very familiar, very comfortable with drawing all of the components of it that we discussed in this lecture. There are certain things, of course, that we didn't really discuss. The one that you should be able to do, with ascending blood flow into the aorta, that's pretty intuitive. So, of course, during systole, as soon as you exceed aortic pressure with the ventricular pressure, you'll have ejection of blood into the aorta, and otherwise you won't have ejection of blood into the aorta as long as the aortic pressure is higher than the ventricular pressure. So that's one that you should know. But when you're looking at other things like jugular venous pressure, you don't need to be familiar with that. You don't need to be familiar with the leaflet positioning here as well. But you do need to be familiar with the pressures that are generated on both sides of the heart, blood flow, the electrocardiogram, the heart sounds that are generated, and as well as the changes in thickness that occur over the course of the cardiac cycle. And so hopefully this has been clear here, and we'll have a subsequent uploaded video where I will go through some of the strategies that I think will be helpful in having you draw and depict changes in the Wiggers diagram over the course of the cardiac cycle and in response to various insults. Thank you.